That very conveniently brings us on to Anne. So will I share my screen, Anne? Or no, you're fine. Grant.
Hi, and thanks a million. I observe we're about 30 minutes behind, so perhaps I'll do some time warp to gather us 25 minutes. But I'm delighted just to have the opportunity to talk about maternal, newborn and child health in Malawi. This was a previous project. Now, it actually finished in 2015, but the paper upon which this poster was developed is cited down the bottom here, finally got published in 2019. I suppose we were working in a big team, and we all were determined to really disseminate as widely as we could. It was a 3-year project, community system strengthening for equitable maternal, newborn and child health in Malawi, led by the RCSI. We were leading the learning technology part of it. Lisa Donaldson came first to work in DCU as part of this project, and in fact her sister designed that beautiful logo, which is kind of the mother and child, very typical Malawian craft. So in a nutshell, this was presented virtually at the Bali, which none of us were in Bali, ICM, the International Confederation of Midwives Congress, which takes place every 3 years. So it did take place virtually this year. It was scheduled for 2020. So this abstract was actually put in, I think, in 2018. But the reason why I just want to kind of highlight it is because when this paper was first, I led the analysis for this. It was 85 interviews with various people across communities, health surveillance assistants who are community health workers in Malawi, village chiefs, religious leaders, all kind of then women, grandmothers, people who use services, people who don't use services. And it was just, there was such an amount of data gathered really. And I had written a paper about perceived risk, giving birth at home or in the health facility. And what a lot of women were saying is because the health facilities were so poor that actually the risks were greater to go to the health facility than give birth at home with a traditional midwife with no emergency services at all. I submitted that paper and they came back and said, oh, this isn't really about risk. So coincidentally, on the Masters in Community System Strengthening, we've been using this framework, LEVESC, about access to healthcare. And I suppose this whole project, the COSIS project, tried to highlight not just the kind of supply of health services, but also the demand, because there was a sense from previous health system strengthening research that you could build a health system, you could strengthen it, but what about the community systems that would enable people to reach out for these services? So this framework fit really well. So the bottom layer here are the kind of demand factors and the top are the supply. And this is all about access so that you would finally get to, to have an improvement in health. So I definitely won't go through these, but I just restructured it according to this framework, resubmitted it, and it was accepted. So that's just a lesson in perseverance when your paper gets rejected. When it doesn't make sense, because you have a notion about something and it's not kind of translating. So I suppose overall what we actually felt in the end was that people did know about the services, but they knew how negative they had experienced them negatively before. So actually it was still about improving the services and investing in services. So we were able to examine, what were the kind of demands for services, but really it came back still to a supply, and particularly health workers. So that's been a common thread through a lot of our research. So as this led on to the current project we're working on in Malawi about policy implementation for maternal and newborn and child health, just to say it was done with Concern Worldwide, Concern Universal initially, the RCSI and the University of Malawi, and that's our team in Malawi, and they're just the two references, the finally published paper and the LEVESC framework, which I've used again and again because I think is actually really helpful to really think about that kind of, how can people perceive, seek, reach, pay for and engage in services, as well as just us providing services as we see fit. So thank you, and apologies for the brevity, but probably necessary at this stage.
Your time machine is clearly working really well, Anne, so thank you very much. Questions for Anne? That really interesting paper. Can I ask you a question, Anne? In Malawi itself, how far is the health service taking on these ideas, these issues?
Yes, good question. So in that case, I suppose we were linked back with the ministry. And I suppose we learned a lot from that project about how to engage with the ministry maybe early on. So the ministry, and in the current project on infant feeding policy, we actually didn't decide the focus of the project until we got to Malawi in 2019. Met the ministry, the Department of HIV and Nutrition, and went around meeting everybody currently working in Malawi and said, look, this is what we'll focus on: the Baby Friendly Hospital Initiative and care groups. So I think that project in a way reinforced what people already knew. And I think that was a difficult thing for us all, that there weren't enough services, that the services were 15 kilometers away. Women had no transport. When they got there, there was one midwife maybe asleep because she worked 3 days in a row. So, actually the level at which that can change is really, challenging. But I think definitely this time around, from a more translational point of view, I suppose we were lucky in that we got IRC funding with a fairly broad brush about evidence-based policy implementation in maternal and newborn and child, nutrition. And we were able to kind of figure out first what would be a priority for the ministry and the Department of HIV and Nutrition, and then kind of work with them to design that and have them on board. And I suppose that's what we found now. We've gone back to the ministry and other people in the reproductive health department on 2 other projects, and they've supported us applying for them. So it's still really difficult because we could present the findings back, and there just isn't enough investment. Services haven't improved. Maternal, newborn and child health services haven't really improved. The HIV services did. And the more they were integrated with maternal, newborn and child health, the better women in pregnancy did related to HIV. But the maternity services still are very poor. And Malawi, it's very, a peaceful country, but just, very, very little actual, development. Definitely moves afoot. And we're looking at things like solar power projects now, working with electronic engineers. So I think we're trying to get more as well with, what's happening in the country, and trying to just work with those, because the problem with that RCSI project was, the way that funding was structured, it was very much led by the global northern institutions. And this time, we're kind of working from the southern institutions upwards, I think.
Yeah, I think that can work better. I mean, we certainly had that experience in Uganda with the Water is Life project, which was completely led from Uganda. And all sorts of things happened that we would never have thought of in 100 years. But it may have been much more useful for all that. Any other questions for Anne? Okay, so thank you very much.